Thank you, Dr. Abhishek. Thank you, Ashok sir. And it's overwhelming to be amongst juniors as well as our role models and our teachers, Sushma ma'am, Mala ma'am, Dr. Rita, Dr. Kirti. We all have been actually, we look forward to them, and it's actually overwhelming. Thank you so much. It's good to see so many colleagues and now becoming faculty in front of us. So the topic for given to me was feed intolerance and necrotizing enterocolitis. So at the outset, you can see that the terminologies, even the topic says feed intolerance oblique NEC. So we as neonatologists are always cautious, worried. We don't know which feed intolerance to actually label as NEC. And post feeds, this topic seems quite relevant. We'll see what features actually qualify to be really called as feed intolerance in a newborn, just like in an adult maybe. जब हम कुछ ज़्यादा खाना खा लेते हैं तो पेट फूल जाता है, पेट भर जाता है. So whether that should be called a pathological condition or whether it's a part of physiology of the immature gut. So these are the controversies sort of and dilemmas which exist. And the topics where evidence is not there, no, there is evidence, but फिर evidence ऐसा होता है कि इधर भी है उधर भी है, जैसे आप उसको इम्प्लीमेंट करना चाहो वैसे इम्प्लीमेंट हो जाएगा एविडेंस नहीं. ये भी ऐसा ही टॉपिक है. देयर आर स्टडीज विच आर देयर कि इसको प्रिवेंट कैसे करना है, डिफाइन कैसे करना है, बट देन वी आर स्टक अप आल्सो समटाइम्स whether it is really applicable in our context or not. And morning I had listened to 2 talks and I could grasp that you all now know that our population, our study population, our babies are different. We have more small for gestational age babies. We have more IUGRs. The babies who are actually fetal growth restricted and have Doppler changes. So उन बच्चों में क्या करना है अभी भी Western हमें guide नहीं करता है, West हमें guide नहीं करता है. So we have to make our own protocols. We have to observe clinically. We have to decide how to practice what is the evidence which is there available. So those I will try to touch upon the messages. Slides are there जिसमें forest plots हैं, जिसमें evidence है, but उसके नीचे key messages भी हैं. So I will try to clarify as much as possible. As I said, सबसे पहले कोई भी topic start करने से पहले we should know how to define. So इसका definition ही थोड़ा dilemmatous है, I mean confusing है. Abdominal girth ले. Should we take abdominal girth in all the babies and then see after feed whether the girth is increasing? Should we take pre-feed aspirates as a marker of feed intolerance? Or कोई और parameter ले? What should we look at to call it actually a feed intolerance? So I tried to go through the available studies and literature. So girth. Randomized control trials नहीं है. There are no randomized control trials. And I think it would be difficult also. I'll tell you why. तो एब्डोमिनल गर्थ को देख के किसी ने ऐसा प्रेडिक्ट किया हो कि इसको NEC हो गया या देयर इज मोर्टेलिटी व्हिच इज अकरिंग बिकॉज ऑफ इंक्रीज्ड एब्डोमिनल गर्थ, देयर इज नो स्ट्रॉन्ग एविडेंस. सिंगल कोहॉर्ट स्टडी है एंड दे आल्सो एक्नॉलेज दैट एब्डोमिनल गर्थ itself is a subjective phenomena sort of. The person who takes it, even 0.5, 1 centimeter tak ka bhi difference they have noted, right? Sisters who are taking, plus which time they have taken, how much feed and how much stool the baby has passed before that, what time exactly after what time of the feed the abdominal girth has been taken. So those were the issues which they have acknowledged. So the evidence is very low quality. The message from this slide is abdominal girth as a predictor of feed intolerance has a very low quality evidence. Okay, because it's a group of fellows also here, postgraduates plus faculty, we all are here. So let us connect the evidence with practice, right? So the evidence is low quality. Now, what if we combine abdominal girth with pre-feed aspirates? What does literature say about this? So now again, we are stuck. They say that minimal role of gastric residual volume as a predictor of, again, NEC or mortality, which are the hard outcomes. NEC is relatively well defined and staged. You know? We know there are certain symptoms, there are X-ray findings by which we label NEC. Again, suspect NEC as a gold standard again is a little subjective. Whom do you call the suspect NEC? So all these studies have these limitations, the feeding studies. And as I said, significant inter and intra-observer variability in measuring the abdominal circumference, even up to 3.5 centimeter. So अगर 3.5 सेंटीमीटर की वेरिएशन आ रही है, so 2 सेंटीमीटर की जो डायग्नोसिस है वो अलोन तो प्रेडिक्ट नहीं कर सकती, it cannot predict. 2 centimeter alone cannot predict. So the message from this is that even if you combine with pre-feed aspirate after each feed, then also it's not a very good predictor. If you take only pre-feed aspirates, so what do they see? Again, the quality of evidence is low here. There were 3 randomized control trial and where sepsis and NEC were taken as critical outcomes, and they found no effect of pre-feed gastric aspirates. In fact, what they saw was that routine pre-feed aspirates leads to increased risk of NEC, delays the time to reach full feeds. बार-बार aspirate करके देखेंगे, 1 ml आ गया, 1.5 ml आ गया, जो ऑन फ्लोर वर्क कर रहे हैं, सिस्टर्स हैं, रेजिडेंट्स हैं, हम लोग भी मिडिल लेवल जो अभी वी हैव फिनिश माय रेजिडेंसी एंड आई एम स्टिल फ्रेश फ्रॉम माय मेमोरी, तो हम लोग भी डर जाते थे। अब प्री-फीड एस्पिरेट हर बार कर रहे हैं, 1 ml आ रहा है, 0.5 ml आ रहा है, क्या करें? और सुबह डांट पिटती थी, ये 0.5 ml भी क्यों रोक दिया फीडिंग? नहीं, सो प्री-फीड एस्पिरेट जितना कर रहे हैं, डिले टाइम टू रीच फुल फीड्स and no difference in the hospital stay. So this is the level of evidence, very low to low quality evidence. So evidence hai, but it's not strong. So based on this, a systematic review, because some were observational, some were RCT, some had lesser sample size was low, and the outcomes were heterogeneous. Heterogeneous मतलब किसी ने कोई outcome पढ़ा, किसी ने कोई outcome study किया. Even जो measurement था, eligibility criteria, how to define, those were also different. तो ऐसे में जब pool करते हैं evidence, it's not a very high quality evidence, because somebody has done something, somebody has done something. So even if we pool, we are not able to give a generalized evidence कि वो हर unit में implement होगा. So that is what the NNF says, that it is a low quality evidence, and hence it's a weak recommendation that neither abdominal circumference nor pre-feed aspirates nor combined both. None of them are actually predicting. So क्या करना है ऐसे में? Some people have studied altered aspirates. So altered aspirates, वो दो तीन चीजें subjective हैं, very low evidence है. This is the altered aspirate where the color of the aspirate, if it is bilious, it has been shown to have a relatively, marker of some gut pathology. So you see, not all yellow. Here also, not all yellows are pathological. Once it becomes green, and they have tried to label some names of the green colors. So if it is so, we can actually think of some gut pathology or moving towards caution or NEC. So where are we now? Where do we stand after all these a brief search of the literature? So we stand where the first definition was given by Wilson, which said that gastric residual volume more than 50%, abdominal distension, that is what is disrupting the plan in most of the units. So what I conclude, or what consensus says in absence of very strong evidence, is that don't do routine aspirates, no routine abdominal girth measurement, wash the baby as a whole, wash the baby holistically, contextually, visibly distended, then you measure the girth and then see the comparative increase or decrease. Increase in girth more than 2 centimeters, then only you try to aspirate and see in the next feed, and altered aspirates. So these 3 things, which is visible distension leading to abdominal measurement, which leads to your prescription of having a aspirate, checking the aspirates, and then if they're more than 50% or if they're visibly altered, then you can label as feed intolerance. Then also it's not NEC, it is feed intolerance. So we'll see the protocols. Feed intolerance में क्या करना है, NEC में क्या करना है. अगर एक बार ये दिख गया तो ऐसा नहीं है, बंद हो गया तो फिर 2 दिन तक वो जो है NPO नील पर ओरल चल रहे हैं. So feed intolerance is different and NEC is different. So this may mark or point towards a feed intolerance. So इतना सारा dubious evidence के बाद, just because the talk has to be complete in terms of incidence, that's why I have written approx. They say that approx 30%, but then again, It is an overestimate or an underestimate based on the unit which you are working at. Some people may be labeling it as only increase in the abdominal girth as feed intolerance. So we may never get the correct incidence if the standardized definition, operational definition is not standard, right? So just to completion sake and just for give you an idea that we may not actually have an approx idea, even idea of how many preterm babies are having feed intolerance. So let's now move to the scenario or causes. What actually can lead you to think that it is a feed intolerance. Now keep in mind, these are the textbook causes or these are the common causes which we see. Apart from that, there can be some contextual reasons. Can anybody point out what can be the reasons which can lead to any other procedure or any other things which can lead to vomiting or feed intolerance, transient feed intolerance, transient vomiting, transient increase in girth in preterm babies? Yes, very good. CPAP belly. Very good. That's a benign condition. And if you do not keep the orogastric tube open, if you do not provide CPAP care properly, that you may classify as feed intolerance, and then the baby becomes nil paroti. What else? One more thing which commonly happens, and abhi 2 दिन पहले भी round पे we saw. ROP screening करते हैं सब लोग, eye drops डालते हैं. So what does that eye drops do? What do the eye drops do? Dilate करते हैं ना? तो कौन सा एक्शन होता है उसमें मेडिसिन में? एंटीकोलिनर्जिक. तो क्या करेगा? गट को डिस्टेंड कर देगा. देयर विल बी एब्डोमिनल डिस्टेंशन, देयर विल बी विजिबल बाउल लूज, देयर विल बी वॉमिटिंग, एंड यू विल थिंक दैट कल आरओपी स्क्रीनिंग. देन इफ यू आस्क द हिस्ट्री यू सी दैट हाँ कल ड्रॉप्स डाले था, आरओपी स्क्रीनिंग हुआ था, तो आज इसीलिए कल रात को 1-2 बार वॉमिटिंग हुआ. एंड व्हाट हैपेंस? द बेबी बिकम्स nil paroti. So these are some contextual things which you should look at the baby and the paraffin area and the whole prescription and the whole process which has happened with the baby in the last 24 hours, 48 hours before actually labeling it as a pathological feed intolerance or an NEC. So पूरा आपको last 24 hours का monitoring chart देखना है. You have to look at the sisters chart. You have to look उसके साथ क्या क्या हुआ है, क्या handling हुई है, कोई और procedure हुआ है, कुछ pain installation हुई है, something of that sort has happened. CPAP जो है प्रेशर बढ़ाया है, स्लो CPAP का कितना रखा है, all these, and for that you need to have monitoring charts of CPAP. You need to have ROP screening charts in the file. पता ही नहीं है कि ड्रॉप चले हैं, ROP हुआ है, then you will miss it, isn't it? So for that you need to have the full complete baby history and examination with you before you actually direct that these are the causes. So these are the causes, and these are well documented, and I will not go into the details. That extreme prematurity, asphyxia in a term baby also can cause feed intolerance. Okay, NEC in a term baby has very few causes, and one of them is severe asphyxia. Fetal growth restriction with Doppler changes. So you must be seeing now कि ultrasound का जैसे evolution है. A lot of mothers now come with Doppler readings in their antenatal ultrasounds. So now अब Doppler का क्या करना है, किस gestation पे significant है, कितने पे हमें withhold करना है. So these all things actually are contributing more and more to the burden of what to say nil per orally वाला जो group है उसपे. तो अब Doppler changes जब से evolve हुए हैं last 4-5 years में, we have seen that now every mother with IUGR or without IUGR also term gestation पे भी कई बार Doppler लेके आ जाता. So Doppler changes is one thing that's why I have highlighted it as red. And of course NEC. NEC एक अलग term है, pathology है, which requires a triad जो हम अपने undergraduate, postgraduate level से पढ़ते हैं. What triad does it require to happen? Preterm, formula and sepsis. All these three things होते हैं तो necrotizing enterocolitis is then happening. एक factor होगा तो usually it doesn't happen. And then of course septicemia and septic gut. So I mean we see in our units last week also, 15 days back also, in the last institute also we used to see NEC label हो जाता है, but what happens is उसका culture positive है, उसका और septicemia, sclerodermia, everything is happening to the baby. So why to blame only on feed? Why to withhold feed? Why to blame कि feed दिया इसीलिए उसको NEC? So that is not the case. There are things which are happening around the baby which is contributing to his gut becoming pathological, right? So NEC is a separate term, and all the above things they may contribute, but they alone will not lead to feed intolerance. So आपको withhold करने की पहले से जरूरत नहीं है. You should not get discouraged or demotivated कि इन बच्चों में हम शुरू ही नहीं करेंगे feed. Right? I want to go into that कि feed intolerance जो है पर से नहीं होगा unless we have given extra something to the baby. ऊपर से कुछ दिया है तभी उसका gut जो है that will become pathological. So I'll just touch upon this scenario because the studies have, there is a recent evidence. So abnormal Doppler, we all know absent and reverse and diastolic flow. What does it do? How biologically it is plausible that the gut is affected? It is affected to a certain extent because brain sparing effect is there in IUGR babies. Blood जो है वो सारा intestine से brain में जा रहा है. It's a vital organ. So there is some amount of ischemia which is happening in the gut. Evidence also shows, biological evidence also, that mesenteric arteries में first 7 days में flow थोड़ा कम है. But ये clinically meaningful data में convert हो रहा है कि नहीं? That we need to see. So there was this meta-analysis which was done, and this was the basis of doing the ADAPT trial, जो एक landmark trial है, ADAPT trial. So इसमें देखा कि 2.3 odds increased हैं in abnormal Doppler babies to have NEC. But then again, एक दो ही large studies थी which contributed to the results. Any meta-analysis, whatever studies you put in, results भी वैसे ही आते हैं. So we need to see the quality of the studies, the heterogeneity of the studies, what parameters they have taken, how they have diagnosed the Dopplers, all these things we need to see. So this has had some limitations. So this multicentric randomized trial was done, and this was done from UK and Ireland. 54 units, they enrolled abnormal Doppler babies, and they found that 29 weeks से कम में there is a chance that NEC can happen. Beyond 29 weeks, above 29, equal to and above 29 weeks, there was actually no difference. Okay, when they started feeds. But इसमें भी catch है या caveats हैं. As I said, जब भी कोई study होती है, you have to look at the methodology. And इसमें methodology में था कि feed volumes, they had given a lot of discretion to the clinician. तो जब 54 units में clinician discretion आता है, तो there is a disparity which can occur. So I just want to highlight that there are RCTs, there are meta-analysis, but please keep your eyes open for your own unit and please raise questions in your own unit whether हमारे बच्चों में ही applicable है कि नहीं, क्योंकि वो भी हमारी तरह clinicians हैं who have taken these decisions of starting feeds to stopping feeds. So there we see that feed volumes could be altered or stopped at the clinician discretion, and enteral feeds were actually continued where the aspirates were less than 2 to 3 ml. So वो लोग भी, they had given the feeds even in abnormal Doppler, even when the aspirates were up to 3 ml. So you see, these are the caveats in the trial which we actually convert into policies or what to say guidelines. So please remember that. Just take home ये message करिएगा. So there is still clinical equipoise in gestation above 29 weeks. कि Doppler changes हैं और above 29 weeks है, तो क्या सच में 24-48 hours तक उसको nil orally रखना है? वो अभी भी equipoise है या क्या कहते हैं उसमें भी doubt है, मतलब balance है अभी, imbalance है या whatever. So with this background, अभी भी हम डरते हैं. This is our situation as a neonatologist, and ऐसे मैंने बोला मैं other side of the round भी रह चुकी हूँ as a resident. So we always used to say नहीं सर इसका तो abdominal gut थोड़ा सा, अब वो cross check होता है हमेशा कि नहीं दिखाओ कितना बड़ा है gut, feed aspirate क्यों किया नहीं. So we are always running on a tight rope कि whether we should actually stop feed, give feed, एक sign आ गया तो बंद करें, दें, क्या बताएं, नहीं, isn't it? So it remains, the situation remains. So मैं बस I'll just touch कि कहाँ पे आप NEC suspect करते हो. You see there is a, it's much lower down. When you see that there is a visible distension and the abdominal girth is more than 2 centimeters, then only you measure the abdominal girth. When you have seen that there is a visible distension on clinical examination, don't forget the clinical examination after ruling out all the context of the baby. Baby should not be having any CPAP belly, baby should not be having any other medications, any other reason for his so-called visible distension, right? And then you see whether what are the aspirates and the nature and the volume of the aspirates. And नीचे जाके 50% से ज़्यादा जो feed है, then also पूरा 24 to 48 hours NEC की तरह नहीं manage करना है. You have to withhold and see again. Again go back to the girth, again go back to the aspirates, withhold 1 or 2 feeds. And then if again feed intolerance occurs, then you see for the systemic signs. As I said, after ruling out the holistic situation of the baby, if there are systemic signs or if there are bile or blood stain, as the green color which I showed you, then only the stage comes where you can consider NEC. So you see, यहाँ पे NEC नहीं सोचना है, first point. There is a lot more to be seen before you actually label the feed intolerance as NEC. Okay. So ICMR now has given some the flow chart, one-page flow chart, where they touch upon the Doppler change babies also. And since pehle we used to think that 24 to 48 hours tak hame nil orally rakhna hai. Now the duration they have reduced to 6 hours. We used to see whether the baby has passed stool or not passed stool. कुछ साल पहले वो भी था, अगर stool pass किया तब दे देना. Asphyxia है, stool pass कर दिया, then you give feed. Doppler changes है, but stool pass कर दिया, then you give feeds. But now abdomen soft है, कोई distension नहीं है, then you can actually start after 6 hours. And remember and see that this is for gestation less than 35 weeks. More than 35 weeks, 36 weeks, 37 weeks में AEDF कुछ आ रहा है, it doesn't matter the Doppler changes. Okay, so beyond 35 weeks, you can actually start with full feeds, and less than 35 weeks only. This is evidence-based ICMR guidelines, and most of the units, I think, they are now moving towards early advancements. Red flag signs are there, which we have already talked about, that systemic signs. Other systemic markers of sepsis or contextual evidence of baby having systemic signs of cautious newborn condition like sepsis or NEC. NEC, sepsis की वजह से अगर है, then these are the red flag signs. Of course, altered aspirates, blood stained, they are also a marker. So once we are now here that how to actually approach the feed intolerance and when to actually go about, go and suspect NEC, just a marker that prevention for anything in newborn, less is more, and prevention is always better in a neonatal care unit, be it sepsis, be it feed intolerance, be it any ROP. So any pathological condition you see, पहले ही आपको obsessed होना है कि भाई होना नहीं है यूनिट में. एक बार हो गया तो obviously there are strategies, फिर ये देंगे वो देंगे, but the prevention is always better even for adults also. For us also हम कहते हैं कि blood pressure, diabetes prevention is better, isn't it? So steroids we all know, I won't go into. 50% reduction है. I hope delayed cord clamping हो रहा है सबके units में. नहीं हो रहा है तो whenever you go and attend the deliveries, do make sure that delayed cord clamping is done. Not only other benefits, since the talk is on NEC, I will just say that 40% reduction in NEC hai, because there is better circulatory stability and lesser need of transfusions ahead. Mother के antibiotics पे जरूर keep a watch or keep talking to the obstetricians. I'm sure they must also be knowing. Coampicillin in PROM has been shown to have increased risk of NEC in newborns. So obstetricians से हमेशा even for delayed cord clamping, antibiotics, sepsis risk factors, inducing delivery before 39 weeks, in सब चीजों के लिए you have to talk with the obstetrician, right? So keep collaborating with them. Postnatal strategies, there are मतलब आती है कोई product आता है, lactoferrin आता है, neopepsin आता है, something comes in the market, they study, then multicentric studies, it gets published, but what is actually proven or what is the best? And the first the gold medal goes to feeding practices and strategies. So it works the best because बाकी सब, even if you give, जो dividends देंगे वो आपको यही देंगे, adherence to the protocols. That will give you more rewards. And this I'm speaking from the experience of 3 or 4 institutes where I have worked, and all 3 have been different types of units. One overcrowded, one ideal or what to say low burden unit, and one where the burden is comparable to any Indian unit. But then what can protocols do? How it can change? So we have to see to believe it, and I'm telling from my own first-hand experience that feeding practices, I have seen that these are the ones which work, irrespective of whatever you do, probiotics दे रहे हैं, GMF दे रहे हैं, whatever you are doing to protect the gut. If you give the enteral feeds and if you follow the standardized feeding regimen, अब standardized feeding regimen होता क्या है? There is a systematic review that says that significant reduction in the NEC, 80% reduction. But होता क्या है? They have said that any protocol which you adhere to, ऐसा नहीं होना चाहिए कि ऑन फ्लोर पर्सन पे या राउंड पर्सन पे बेस्ड है कि आज फीड शुरू हो गया, कल बंद हो गया, शाम को शुरू हुआ, सुबह बंद हो गया. स्टैंडर्डाइज्ड एडहेरेंस टू द प्रोटोकॉल, स्टैंडर्ड प्रोटोकॉल, और उसके लिए जैसे डॉक्टर गिरीश भी अभी कह रहे थे, नॉलेज, एटीट्यूड, बिहेवियर. These changes for every domain of neonatal care, you need to change yourself and the team first. सबकी टीम को बिलीव कराना पड़ता है अपनी टीम को कि yes, this can happen. You have to show the results. You have to see the baby daily, show them and see yourself that this makes a difference. So that is what actually 80% reduction इसी से मिलेगा. I need not tell you, I think science of breastfeeding has been covered. So ये biologically, microscopically सब जगह proven है. 38% तक reduction है. And each एक proportion से भी बहुत फर्क पड़ता है. 25% increase से आपका 38% NEC reduction. So imagine what can talking to mother. And this also is important, talking to the mother. जब भी पहली बार वो NICU में आ रही है. Making her do KMC, allaying her anxiety, just 1 or 2 sentences after the rounds or during the rounds, that would help. Minimal enteral nutrition, if not practicing, please practice. I won't say कि drastically जाके सबको fulfill शुरू कर दें. Even if you start minimal enteral nutrition to begin with, 15 ml, 20 ml in the babies where you are scared. If you do that, over months, you can actually build upon that. Slow versus faster rates, I have included this because it's a recent Cochrane 2022 का, जिसमें उन्होंने SIFT trial include किया है for the fellows and all. SIFT trial is slow increment versus fast increment trial है. उसकी भी कुछ limitations हैं. Day 4 पे they have started giving full feeds sort of thing. जबकि हम और gestation specified नहीं है, very low birth weight babies लिखा है उसमें. तो 1500 is too big a baby for us. हम तो 1500 में start कर देते हैं. So every study, look at the methodology, look at the limitations before actually implementing it straight up. So Sushma ma'am is sitting here and globally has been recognized. There are challenges, there are issues, but as I said, begin with maybe a first change, which is starting minimal. शुरू करने का एक बार हिम्मत करें, courage लाएं, so you can start full feeds also. So we have also tried at Sabdajung also, we tried to do some standardized feeding regimens. But every unit has its limitation. Probiotics मुझे भी doubtful लगता है, इसीलिए मैंने डाला है. I think we were discussing during lunchtime also. So है biologically proven role है, plausibility है, and there are different regimens which have been tried. Mostly Deshpande, Sanjay Patole sir, Australian group है, which have studied its role, and they use it also very often. But कुछ controversies हैं. जिस पॉपुलेशन में ज्यादा NEC है, एक्सट्रीम लो बर्थ वेट में, उसमें डेटा नहीं है या प्रूवन नहीं है तो बेनिफिट. क्या डोज देना है वो अलग अलग स्टडीज में अलग लिया है. विच स्पीशीज और विच स्ट्रेन टू यूज वो हर स्टडी में अलग है. ऑल्दो देयर आर 50-60 स्टडीज विच आर देयर जो इन्होंने ऑब्जर्वेशनल स्टडीज को लिया है. इनिशिएशन और ड्यूरेशन ऑफ ट्रीटमेंट बहुत वेरिएबल है. प्लस सेफ्टी कंसर्न ये है कि वेदर इट्स अ फूड प्रोडक्ट और वेदर इट इज मेडिसिनली प्रिपेयर्ड, वो एक डाउट है. सो मैन्युफैक्चरिंग इश्यूज हैं. सो हम ये तो नहीं कि उसको सेप्सिस ही और दे दें, ऐसे पुड़िया निकाल रहे हैं उसको डाल रहे हैं, वेदर इट इज मेडिकली मेड और नॉट, दैट इज एन इशू. सो डोजिंग का बहुत सारा स्टडीज हैं, वेरिएबल डोजेस स्टडी की गई हैं, डेली, ट्वाइस डेली. सो जो यूनिट्स प्रैक्टिस कर रही हैं, आई ट्राई टू कोलेट इट, जहाँ से ऑस्ट्रेलियन है या इंडियन में भी आई थिंक 40-50% यूनिट्स अभी यूज कर रहे हैं. So what they are doing is they are giving in birth weight above 1000 grams, जिसमें कि हमारा baseline NEC और feed intolerance as such ही, जहाँ अगर आपने sepsis control कर लिया, other protocols uniform है आपके, NEC rates in this group more than 1000 gram में आपको जरूरत नहीं पड़नी चाहिए. What we have seen in all the 3 units which I have worked, 3 or 4 units, what they are using is multiple strain of lactobacillus and bifidobacterium, and they start at 48 hours and give till 37 weeks. I think unit is also practicing, maybe they can also share their experience, and regular monitoring for systemic complications. One more practical doubt which we usually have is whether we should withhold feeding during blood transfusion or not. How many of us are actually withholding the feed if you are giving blood transfusion? कोई नहीं withhold कर रहे? So है systematic review है again, but if you go deep into that, they are all observational studies. Obviously RCT नहीं कर सकते कि किसी को blood दे रहे हैं और ये कर रहे हैं, blood दे रहे हैं ये नहीं कर रहे हैं, because blood transfusion is a then and there decision perhaps, and then ethical issues. और last included study 2016 में थी, जो कि almost अभी 7 years हो गए हैं. उसके बाद में restrictive policy of transfusion आ गया. So if you practice delayed cord clamping and if you prevent the iatrogenic anemia, आप देखोगे कि ब्लड ट्रांसफ्यूजन का रेट इटसेल्फ ही आपकी यूनिट्स में बहुत कम है. और वो अदरवाइज बच्चा स्टेबल है, ग्रोइंग प्रीटर्म है, 6 वीक्स पे अगर उसको अनीमिया ऑफ प्रीमेच्योरिटी हो भी रहा है विच रिक्वायर्स वन ऑफ ब्लड ट्रांसफ्यूजन, वी आर नॉट स्टॉपिंग इन आवर यूनिट because that's a growing well baby. In a sick baby, of course, who's requiring blood transfusion because of sepsis, DIC kind of picture, वो वैसे भी फीड पे नहीं रहेगा. He will be in shock, he will be on inotropes, he will be sick. So in our unit, one of जो बहुत rarely blood transfusion अगर दे भी रहे हैं preterm growing में, we are not withholding the feeds. So please try to prevent this also, blood transfusions in your unit. Avoid prolonged antibiotics. एक moral support रहता है, antibiotic पे है तो NEC नहीं होगा, which is totally wrong. उल्टा वो ज्यादा इंक्रीज करता है NEC का रेट्स, डेथ भी. सो प्लीज बी वेरी कॉशियस. इट्स अ सेपरेट टॉपिक ऑल टुगेदर फॉर अ डे. सो व्हाट वर्क्स इज 5 थिंग्स आई वुड से. एंड क्वेरी प्रोबायोटिक्स इसीलिए है कि मोस्टली दे आर प्रैक्टिसिंग, बट टू शेयर माई एक्सपीरियंस, वी आर नॉट गिविंग प्रोबायोटिक्स इन आवर यूनिट. बाकी सब यू ऑल नो, प्रिवेंटिंग द प्रीटर्म बर्थ, एंटीनेटल स्टेरॉइड्स, डिले द कॉर्ड क्लैंपिंग, बट इम्प्लीमेंट करना है इन सब चीजों को. Human milk, standardized regimens, asepsis. I think sepsis is the most important collaborative thing which actually leads. And don't give H2 and receptor. अगर aspirate आ भी रहा है ना, non-altered, greenish नहीं है, yellow है, तो ये pentoprazole और H2 receptor antagonist नहीं काम करेगा. Please don't give. And don't prolong the antibiotics unnecessarily. वो protect नहीं करेगा, वो enhance ही करेगा risk of NEC. So my take-home messages would be that feed intolerance may be often overdiagnosed by us, including me, and identify and treat the baby as a whole. See in the last 24-48 hours उसके साथ हुआ क्या है. Don't find कि मुझे नहीं देना है. In fact, आप reason दो कि मुझे देना है, at least minimal enteral nutrition देना है. अपने feeding regimens को, जो भी feeding regimen, above 1250 देना है, आप above 1250 दीजिए MEN. above 1000 देना है, above 1000 दीजिए, but उसको adhere करिए. Start adhering to the protocols, asepsis routines in place, because NEC सिर्फ milk से नहीं होगा. There has to be a precipitating sepsis factor in it, and prevention is always better than treating it. Thank you so much.